for treatment. I think, Anne, you mentioned a number of things here. There's now also out this urolithin A that people have been interested in, which is supposed to enhance this PINK1 Parkin pathway, which has been studied in Parkinson's for a while. To me, one of the most intriguing things that came up with Parkinson's several years ago was that if you just inhibit mitophagy, so you just inhibit the recycling of your mitochondria, so essentially you're allowing your batteries to wear down without recycling them, you develop Parkinson's. So this is an important pathway to break these things down, just like you do autophagy. This is mitophagy. You're engulfing your mitochondria, breaking them down, recycling the parts basically, so that you end up with a more active mitochondria. And this is what urolithin A is supposed to be doing. You're also supposed to be improving the potential with TUDCA, which is a bile acid related compound that people are using as well. So I think there are lots of possibilities here. Also, things that are antioxidant like curcumin and anti-inflammatory, I should say, and anti-inflammatory things like quercetin can be helpful as well. As Anne said before, getting the glutathione up may be one of the most important things. And then she mentioned the high dose B1. Dr. Hidea has actually been interested in this as well. One of the things that we haven't talked about that's been intriguing to me, because it makes sense theoretically, is to look at methylene blue. Because in Parkinson's, you've got something, these various toxins are inhibiting your mitochondrial complex 1. And essentially, the methylene blue offers you a pathway around. So it's almost like you've got the freeways all crowded. This is giving you a surface street to go around a backup and ultimately get you to complexes 3 and 4 and potentially allow you to have some energy. Now, people are looking at trials on this for Alzheimer's as well. I won't be surprised if this turns out to be an important part of the armamentarium for the future for Parkinson's disease. And then stem cells. This has been one of the things that's responded pretty well to stem cells, both autologous and the allografts. And then we did talk about mucuna pruriens, which has essentially is looking at increasing your L-DOPA, your presynaptic dopamine. Now, what the classic training is, you've got presynaptic, which are down in the substantia nigra, down in the brainstem. You've got the postsynaptic here up in the striatum, the caudate and putamen. And so as the disease progresses, you lose the presynaptic element. So now it doesn't help to give something that's presynaptic. Now you have to give something that's postsynaptic, and that's where people use bromocriptine. And bromocriptine binds directly, so that can be helpful. As Anne mentioned also, the MAO inhibitors like selegiline, which are preventing you from breaking down that dopamine, so they can be helpful as well. And then there, of course, some of these same sort of stimulation approaches that people take with Alzheimer's. So that's a lot of stuff, but it just shows again that the armamentarium is large. If you get in early, if you know what to look for, getting in early is huge, starting early. There are better and better tests for earlier and earlier in the disease process and less invasive and less expensive. You don't necessarily have to get a PET scan to look at this. So I think with all these things coming together, we should be able to reduce the global burden of Parkinson's disease by getting in early. We should really be looking more at widespread prevention programs and looking at people who have some of these earliest symptoms.